Hi, welcome to the case review community. This is Tim Moss again, and here I'm greatly pleased to introduce Dr. Raj Valvani, one of our members from Marietta, Georgia. Just a brief introduction for Dr. Valvani. He is a physical medicine and rehabilitation physician. He did his PM&R training at Emory University and subsequently a sports and spine fellowship at Beth Israel Medical Center in New York, and now practices in Marietta, Georgia. And he has brought us a very interesting case, which we will have him present. So I'm going to turn this over to Raj as he starts the case presentation.
Thank you, Dr. Moss. This is a patient I saw in clinic a few months ago. It was an interesting case for me, so I thought I'd bring it forward. It's a 46-year-old male who 10 days prior to seeing me had a fall on his sacrum from a chair height. Immediately after this, he did have bilateral upper and lower extremity paresthesias. Since that time, he has had some improvement in his numbness and tingling, and it was now only limited to his fingers and toes. He has had persistent difficulty walking with numerous falls over the past 10 days. He has had no bowel or bladder symptoms. He originally presented to the urgent care and he was referred to Pinnacle Orthopedics for us to evaluate him. Prior medical history, he does complain of some gait disturbances in child and adolescence. He did have poor coordination growing up. He actually stayed away from most land sports because of this and became an Olympic caliber swimmer. He is vaccinated, has a history, prior medical history of bipolar disease, depression, anxiety, and hypertension. Medications he was on was Advil, Cymbalta. He was on the Cymbalta for bipolar disease, depression, and anxiety, Lunesta, Klonopin, lisinopril, and Depakote. On physical examination, he did have an ataxic myelopathic gait, which I'll be showing you in just a few minutes. Strength-wise, he was good in both his upper and lower extremity strength, with exception of his bilateral EHL. Reflexes were normal with the exception of the patella and Achilles, which were both hyperreflexic, and his sensation was intact, but he did have decreased proprioception. This actually is a video of when I saw him back at his follow-up visit. So his gait had improved a little bit from the initial visit to this visit, but this is the video of him walking in the clinic. Just to please observe his gait. So we imaged him in clinic. His cervical spine radiographs were completely, almost essentially normal alignment, had preservation of disc height, no listhesis or fracture. His lumbar spine radiographs were essentially normal with the exception of some just mild degenerative changes at L4-5 and L5-1 disc space. So the questions we bring to the community are, what diagnostic criteria is most likely the causal of this man's signs and symptoms? 1, is it cervical spondylitic myelopathy? 2, cervical cord neoplasm? 3, occult trauma? 4, metabolic? Or 5, infectious? And an additional question that we actually had was, what additional testing should occur? Should we do a metabolic panel, a C-reactive protein, including white blood cells and a differential, a cervical spine MRI, and a SPECT CT? So please answer some of these questions, and over the next few days, we will be getting back to you with some answers as well as some further information.
Thanks, Raj, and we'll look forward to your responses, and then we will see you again shortly. Thanks very much. Take care out there.